Thank you so much for the introduction. Let's get to the main event. We have an hour, I think, to make this work for you guys. So let's dive right into it. I appreciate the introduction. I appreciate the invitation from Glidewell. And also, I think Dr. Barrett was instrumental in getting this established. So really, my focus for you guys today is how to start maybe your first rodeo in the anterior zone. I know a lot of you probably place implants. A lot of you are already comfortable placing implants. A lot of you may already be comfortable placing implants in the aesthetic zone, but I'm going to kind of give you some parameters of what to look for, what maybe to avoid, and maybe it's just some ideas of how to set the case up for success, even if that means that you don't place the implant yourself. Maybe that means that you set it up for success with the periodontist or work with the periodontist in that particular situation. So wherever your skill level is, I'm going to start from the very basics and work our way up of what to look for and how to get that case started and end up with a result that you're happy with. The hard thing about anything in dentistry really is, long-term stability, right? I mean, we can all place an implant. We can also say, wow, look at this fantastic result we got. Look at this papilla. But the idea is that unless we want to move every 3 years to a different practice or a different state, we don't want things to go south on us and we didn't realize what we could have done to prevent that. So I'll show you some pitfalls and I'll show you some ideas to say, should I do this or not? The case that's on the screen I'm not going to show today, but it is one of the cases that I do show. This happens to be one of my wife's best friends. And I begged her, I said, please don't come to me. Please don't let me have to do this case, because the last thing you want to do is have a result on someone that you know personally. And, if anything doesn't make them happy, you don't want that to happen. But, thankfully this case turned out. But I would say for your first rodeo, maybe doing it on a friend is not what you want to do. You want to build that case up with the periodontist or the surgeon, or maybe a more experienced clinician, and then get that underneath your belt. But I am going to show this case right here, and everyone has this that comes in, right? Patient walks in, patient had endo, patient had a crown, patient had a post. It doesn't matter what the scenario is. There's lots of things that we could do, and there's lots of things that we may not want to do. But I'm going to show you what I think the thought process should be when this walks in the door on any given day. Patients obviously distraught. They don't want to walk around without a tooth. You've got to figure out, how am I going to solve this, but not create a different set of problems for myself down the road? This is a different case, and we're going to see this case as we go into here as well. This is also another central. And then we're going to show you a little bit about soft tissue. This is not a course on turning you into a periodontist, but there are some very simple things that you can do. And I want the wheels to spin in your brain, as in, what am I looking for keratinized tissue? Why is keratinized tissue my friend? And when I don't have enough keratinized tissue, what should I be thinking of? And this applies in the posterior as well as, even more important, in the anterior zone when you're working on that right there. But I think every case that you do in the anterior zone, whether it's an implant for the anterior, whether it's a crown, whether it's a veneer, and Dr. Barrett has probably taught you guys very well, is photography, 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 right? We don't have to go to the nth degree, bringing soft boxes into the operatory, but the question is why? I mean, we don't want to take a picture just to take a picture. We want to take a picture because it does something. Does it help you when you sit down and treatment plan? The other part about doing anything in the anterior zone is it documents from the beginning, before you actually touch that patient, what the starting position is. In this particular case, would you say that's a flat papilla, or would you say that's a very high pointed papilla? And before you've even touched a patient, you know that this might be a relatively low risk for you, because there is no papilla present, right? Between 8 and 9, the two centrals. There might be slightly bit more between the central and the lateral. But what you don't want is, you don't want that patient to be unhappy and say, doc, I had this beautiful pink triangle between my two front teeth, and now it's looking like there's a big black space, or my two front teeth look like they're big chiclets. They don't have a shape to them. Then you can go back and say, Miss Smith, unless I was smoking crack that day, I don't remember it being like that. And now you've got something to fall back on. So I'm going to encourage everyone, pictures, pictures, pictures before you plan anything in the anterior zone, in particular an implant like this right here. Now, every case, doesn't matter where it is, starts off with you having the right skill set to get that tooth out, okay? And the idea when I graduated from 96 in Chapel Hill was, they gave me a 301 elevator, they gave me a beaver tail periosteal, a 150, a 151, and a cow horn. They said, go save the world. And clearly, a 301 elevator may not be the right choice in this thing. Now, I know you guys all have your favorite extraction instruments, but I'm going to say we want to preserve as much because it's easier to preserve than regenerate. Easier to preserve than regenerate. I want you to live with that mantra, because anytime we can preserve bone, especially in the anterior zone, that is going to be your friend. Anytime we can not alter the gingival architecture of that case, that's going to be your friend. Anytime we can preserve KT, keratinized tissue, that is going to be your friend. So I want you guys to start thinking of, what do I need to add to my arsenal of things to get out teeth in the most atraumatic fashion? To say we're going to do extractions atraumatically is kind of a misnomer, right? Because it's a traumatic procedure, but we want to keep as much of Miss Smith in her head and only take out what we want to take out, which is the tooth. So in this particular case, if you handed me a 301 elevator and say, there's clearly no way for me to put this in between the tooth, the cribriform plate, and the periodontal ligaments. We need to sever those. So how do we do that? Well, periotomes. If you guys have never used periotomes, I want you to write that down on a piece of paper, and then tomorrow you're going to investigate whatever it is. Periotomes are not 301 elevators that are just cut in half. They're way more flexible. They're kind of a delicate instrument, right? If you go watch a periodontist work, it's almost like they got classical music on and they're going very slowly. You go watch an oral surgeon work and he's going to, blow this thing out to get it out, because he doesn't care about anything else. He cares about getting the tooth out. Now we care about everything because we are doing an implant in the anterior zone. So we got to get something wedged in between there. Now, those of you who have used a peritome, a thin bladed peritome, one that's nickel titanium, one that flexes, you might say to me, well, you're full of crap, Dr. Patel, because I've tried that and I still couldn't get that darn peritome in between. And I get that. There's going to be times that you're taking out a broken down number 6 or 11, and that buccal bone is 0.3 to 0.5 millimeters thick. And you're saying there's no way that even the most thin blade could get in between here. And I agree with you. So when we have the opportunity to go on the lingual, mesial, and distal to create some space for that peritome, start to walk that tooth out, that's what we're going to do. If we don't, we're going to get the $5 solution. And the $5 solution is this thing that you see right here. I get no compensation from Brasseler. Brasseler probably doesn't even know who I am. But this is the Brasseler 859 surgical length burr. Anyone who's been a dentist for more than a year clearly knows that if we put in a regular surgical length burr, what happens when you try to get out a tooth like this? What happens? Well, the burr hits the adjacent teeth. The handpiece does, right? Because it's not long enough. Why they don't make a 28 millimeter long burr, I don't know. But Brasseler makes one. Now, you'll probably go back to the office and say, I want to look for this Brasseler 859 burr, and you'll never find it because it does not exist in the restorative catalog. It's been hidden from us for years because it only exists in the Brasseler periodontal burr catalog. So we're going to make sure that your Henry Schein rep or whatever company you guys order your supplies from, you're going to be able to get this burr because it's 28 millimeters long. Why is it so long? Exactly what you see on the screen. So you could get theoretically to the end of that root without bumping into the adjacent teeth. Obviously, you're going to use a surgical handpiece so you don't cause an air embolism, but you're not using this to section the tooth. You're not using this to cut the tooth in half. You're not using it to do anything except for trace around the tooth root to give you space to insert your peritome. So you're going to go in about a millimeter, and then if you can get your peritome in, great. Mesial distal, and walk the tooth out. If you can't, you go another millimeter and get it out. This is what happens if you put too much pressure on that burr. A third of that burr is missing right there, because if you put too much pressure, it's a very delicate instrument. You'll bend it or you'll break it. So you're not using it to do anything except for be a very fine paintbrush to go around that tooth root so you can get that tooth out. This is also a fantastic instrument to use if you break off a spindly root, like on a molar that's got a dog leg to it, a premolar that's got 2 roots. Rather than blow that buccal plate out with a giant 557 surgical burr, you're going to start to use this right here. Once you put this in your hands, I promise you, you'll say, where was this thing my entire dental career? For those of you who've got an unlimited budget, you might say, well, I've got a piezo. The piezo EXT1, EX2 tips are fantastic because it does exactly what your $5 burr is going to do, which is to trace around that root. Can you see how this right here will go through the mesials and distals, and it'll start to walk that root out? If you don't have a piezo, you've got the $5 solution in your hand, and then you can take that tooth out. So this is that case that we saw. So you can see that we're able to, preserve the gingival architecture, important, preserve the KT, and also get the tooth out with the most minimal amount of buccal bone destruction. That is our goal. That is the first thing that goes through your mind if you're going to be moving forward in this sort of line of logic right here. Now, if you're not feeling the love, you broke the buccal plate, or anything otherwise, you're just not ready to move forward, then what are you going to do with this hole? And the answer is you're going to put something in it, right? Because we want to make sure that at some point, either you, the periodontist, the oral surgeon, whatever, has the capacity to put an implant in there. But before we do that, we got to make sure the walls are bleeding. How do you make sure the walls are bleeding? We got a Miller curette. You scrape it. If it doesn't bleed, then you're going to scrape it again. If it doesn't bleed, then you're going to go grab the serrated Miller curette. You're going to keep on scraping until you start to see blood coming out of those bony walls. I'm not saying you've severed an artery, but you may make sure it's bleeding. If it doesn't bleed, then you take a number 8 round burr with a drill extender and you go in there and you make some holes into that cortical bone because you need some bleeding to happen, because that is what brings in the mesenchymal cells to turn that bone over. What you put in there is dead. It's a scaffold. We got to make sure that we turn that into real live bone for our patient. Whatever magic pixie dust you want. Corticocancellous, osteogen plug. I don't have a preference. I think that's all up to you. Corticocancellous is cheap. Corticocancellous is easy to spoon in. If you can put sand in a bucket, you can do this right here. And then you're going to cover that lid. When I say lid, the bone grafting, red and white, because the walls are bleeding. Keep the good stuff in, bad stuff out. What are you going to do? Well, you could use like an RCM 4.6. You could use a piece of Cytoplast TXT single, but you need to tuck that in 3 millimeters on the buccal, 3 millimeters on the lingual, and then keep all that bone grafting in, because we don't want the patient to spit it out. We don't want the patient to lose it. The other thing is that we don't want to drag and move that mucogingival junction. Could you go underneath this tissue and do some periosteal release and drag that, make a watertight closure? Absolutely. Is that good? Well, if we start thinking about moving that mucogingival junction to get that to close, where have we moved the KT? We have actually moved the mucogingival junction towards a coronal aspect, which is not what we want. We reduce that vestibule depth. So in the anterior zone, I'm going to say moving that mucogingival junction is not going to be your friend, okay? This takes a little bit of practice, whether you're using Cytoplast, whether you're using RCM 4.6, it doesn't matter. But I think getting that underneath there with like the thin-bladed periotome is actually something that's achievable. Obviously, we did it because you see it right here. And then we're just going to put some suture over the top of that. Once again, our lid has to stay there to keep our good stuff in and our bad stuff out. Suture that through, and then we're going to give the patients. Well, what are we going to give them? They walked in with a tooth missing. We didn't place implants, or we don't have the skill set to place implants, or wherever you are on your journey. That's okay, but we want to give them something. In this particular case, we took an impression. We got a little smile transition, so that goes over the top of that. It could have been an Essex. It could have been whatever it is. I get it. If you say, well, I give them a flipper, am I not going to chase the papilla away, Dr. Patel? And my question to you is, the papilla is already relatively flat, so this is a low-risk case in my opinion. If I was on my first rodeo in the anterior zone, I think I'd extract it, grafted, waited, and then come back and do what I'm going to show you as your first case right here. So we delivered the appliance, and now we wait. How long do we wait? 4 months, right? We take our CT scan, and we take our photographs, so we know, once again, where are we starting from? We want to make sure that we've got our buccal architecture the way we want to, our bone architecture, our soft tissue, our KT. These are all things now to evaluate, go over with the patient. So before you touch them, you know, and they know where we're starting from, what our expected aesthetic outcome is, and if we need to punt them to somebody else other than ourselves. I think we did a relatively decent job. Is that papilla grown back? No, it's not going to grow back. Is it where it was? It's probably pretty similar to where it was. Do we have a high mucogingival junction line? I think so. Do we have good KT? I think so. So this is all leading me down to the path of, if I had something to help me put that implant exactly where it should go, would I do this case? And the answer is, I probably would. And I did. So I can document it and show it to you guys. But I'm not going to do this freehand. This is my first rodeo, or maybe it's my 10th rodeo, or maybe it's my 100th rodeo. If I've got access to a cone beam and I've got access to doing a surgically guided implant in the anterior zone, why not? I mean, I think it's going to lead to more success, better implant placement, and less guesswork on my part of where the platform should go to give us the best emergence profile and probably the best outcome. So that goes off to Glidewell, and then you get back what? You get back your surgical guide. For those of you who've not done a surgical guide, you can take the fully guided course. I do teach that. I think there might be a few other instructors that teach that, but we'd love to have you there to show you the sequence of how to make this happen. I won't go into all of the details about guided surgery because we don't have time in 1 hour, but for the anterior zone, we're going to be placing an implant. We're going to be doing it guided, and we're going to be doing it with timing. When I say timing, we know exactly where that platform of the implant is going to go in place. The implant guide is placed, and then we go through the process. Now, here I do want a light bulb to go off in your brain. In the guide sheet, it's going to say, use tissue punch to create tissue punch. Get it, right? We're going to take that keratinized tissue off the dome so we can place our implant. Just because it says it doesn't mean it's so. You still got a brain. I want you guys to use it. And the answer is, should I get rid of that donut of KT? And I'm going to say to you, from now on, I'd rather you make an envelope incision across the crust and push that tissue back than to use the cookie cutter, because if you use the cookie cutter, you've removed what? The diameter of whatever implant you're placing, that much KT is gone. You've taken it away. Will it granulate back in? Yes. Will it be as good as what's there? Maybe, maybe not. So why get rid of it? So here we use a tissue punch. My light bulb is going off in my brain now going, should I do that? Would I do that? And is that the right choice? And the answer is, if I could have kept that KT, I probably would have kept it because I can chase it away later in my temporary or any other time if I wanted to. So have that in your brain going on. Should I use a tissue punch or not? Then you'll go through your steps. It's going to list the recipe card, use start drill, use A drill, use B drill, use final shaping drill, place implant. So that's pretty easy. It's like a 1, 2, 3, 4 step kind of concept. So you just make sure you do that. We won't belabor that for today's webinar, but this is fully guided surgery. So a fully guided surgery, to you, the light bulb should go off that everything is done through the guide. You do not remove the guide until you are done placing the implant. So that way you have the best chance of that implant ending up in 3 dimensions, exactly where you in the laboratory planned it. And also the platform of the implant ends up exactly where you in the laboratory planned it. And you're going to have the thought process of, where should I have that platform? Should I have it like it says in the textbook, 2 millimeters below the CEJ of the adjacent teeth? Should I have it deeper? Should I have it more coronal? And the answer is, we want to make sure whatever diameter implant you pick, in this case, we picked a 4.3 for the central. We want to make sure there's enough running room for the laboratory to give you an emergence profile so it doesn't look like a square on top of the stick or a lollipop on the stick. The other thing that you'll start to get into your brain is, how much KT do I have? If you don't have a native, and I call it the Patel rules of 3, if you don't have 3 millimeters of KT occlusally, 3 millimeters of KT buccally, and 3 millimeters of KT palatally, then you're going to need to create that. So that is the sort of the other litmus test is, just because there's enough volume of bone, you've got to assess the soft tissue, especially in the anterior zone, because that's what's going to give longevity to your case, and that's what's going to protect the implant in the anterior. It's going to prevent recession going on, because we don't want a year or 2 later that tissue to start to creep upwards, and then the patient's like, why does this tooth look longer? Why do I see the metal? All of these things, and this is difficult at that point to fix. This happens to be the final shaping drill. And now we're placing the implant through the guide. Okay, so fully guided surgery, on implant goes through the guide. The platform of the implant will end up exactly where you in the laboratory decided it to be. Guide comes off. You may or may not be able to see. If you look real closely down into this occlusal shot, you'll see the implant inside. Okay, so I think we've done a fairly good job in this guided implant placement. I don't have a perioprobe in here, but I'll just tell you, you've got about 3 millimeters of tissue above that implant. Why is that so important? Patel rule of 3s. If you give that implant 3 millimeters of KT occlusally, you have protected that implant from all kinds of sins in implant placement error or whatever it might be. So just remember that. If you give yourself 3 millimeters, you are going to have robust tissue and a robust case for longevity. Now, if it's your first rodeo and you're not feeling the comfort of putting a temporary on this, or you didn't get the stability, what's stability? Well, torque. Well, I don't really know what I got. I put a torque wrench on there and I got 35. Is that good enough? I would say for anything to load, you need to get 35 Newton centimeters of stability. If you don't, then you're risking a case, especially for single unit anterior. When in doubt, put a cap on it. When in doubt, put a flat cap on it. Come back later, okay? because what we don't want is try to do a revision surgery. Revision surgery, especially in the anterior, is a nightmare case for anybody, even a periodontist, because to grow back, regenerate is almost a uphill climb from the very beginning. So I'm going to encourage you to really look and say, do I want to do this? Patients will push you. Patients will push you, and patients will push you. You're the doctor. You're the doctor. You're the doctor. If you don't want to take on that risk, and I'm going to encourage you not to, then don't load the case if you have any doubts about it. If you have any doubts, save it for another day. Prep the patient for that. This happens to be just a tall healing cap. The patient's wearing that smile composer, so we've got space on the inside of that. So we're not going to load it now. Of course, the patient's going to bang around on this a little bit. So I would not put this 3 millimeter or 5 millimeter tall cap on that case if I didn't have 35 Newton centimeters of stability, or if my ISQ, if you happen to have the penguin in your office, doesn't register in the high 70s, okay? So we got our tall healing cap on. The patient's going to continue to wear their appliance, and we will then either take a biotemp provisional if we had one made with a surgical guide, or we're just going to let that sit, let it heal for 4 months, and then come back with the process of taking impressions. Now, I know you guys might have optical scanners at this point. If you don't, you can take a regular traditional impression. This is a single unit case. I'm okay with the concept of using a closed tray. If it's 2 or more, I'm going to encourage you to do what? Use an open tray. Single tooth, I'm okay with the closed tray right there, which is what this impression analog is right there. You guys know how to do that. You guys have heard of Bruxer Aesthetic. Bruxer Aesthetic, a hybrid abutment. You can do whatever you want to. Bruxer Aesthetic has got a whole lot of translucency. I don't know what you guys have found, but if you put Bruxer Aesthetic next to Bruxer Full Strength, Bruxer Aesthetic is going to look a little gray. So be careful when you start picking shades with Bruxer Aesthetic if the patient happens to have a Bruxer Full Strength adjacent to the restoration that you're doing on top of the implant. It's not the gray of the implant. It's not the gray of the abutment. It's just that material is so translucent. So now we're delivering the hybrid abutment. What's a hybrid abutment? It's a zirconia abutment with a titanium base, because the titanium goes in titanium. 2 similar things going together will flex together. That's why we don't put zirconia on the inside of that implant abutment right there. So we're just inserting it, and then we get it in place. Here it is at delivery. A little bit of blanching of the tissue. That's not terrible. Overall, I mean, because those are not to the left of it is not a Bruxer crown. I think that's a pretty good color match. Now, this blanching, as you guys are aware, will start to dissipate over the next little bit of time right there. But once again, probably a good idea to take a photo the day that you deliver it, so you know where you're starting from and you can see where the papilla is. And now sometimes there might be a little bit of creeping as you push that papilla closer together, but it's not something that I'm going to bank on. And I always explain to the patient, Ms. Smith, just because that papilla is here today doesn't mean it's going to be here a week from now, doesn't mean it's going to be here a year from now, 3 years, 5 years. You've got to understand that just like in your natural mouth, papillas are starting to flatten. This is not a real tooth, and the chances that this papilla staying here do not exist forever. So that's something they have to understand, that we're giving it to them. Take a picture from the lateral side on the day of delivery. You can see that blanching of the tissue right there. And then we get it back in a week. That's starting to look pretty good, right? I mean, that's not bad. It's not perfect, but it's not bad. Then we get it back in 2 weeks. We're starting to see that things are looking even better right there. And then we take a 1-year follow-up. I think that's not bad. Do we see a little black triangle right there between 7 and 8? Yes. Was that papilla there? No, it wasn't. But it's not bad. KT, KT, KT. I always want you to think KT. 3 millimeters across the buccal, 3 millimeters occlusally, lingually or palatally, you're not going to have a problem with that right there. So to review, in this case, you had the patient. The patient came in with a broken tooth. You took the photographs. You prepped the patient. You took out the tooth. You grafted the area. You waited. You came back, took a CT scan. You sat down with the laboratory, planned the implant size, position, platform height. You placed the implant. You didn't even temporize it. You let them continue to wear their A6 appliance or flipper or whatever happens to be. And then you came back and then you took the impressions for the final Bruxer Aesthetic crown right there. If this were your first radio, I would say you did a fantastic job. Prep the patient, prep the patient, prep the patient. Okay, so don't give them unrealistic expectations. If they have unrealistic expectations, that's the perfect patient to say, I don't want this to be my first rodeo. I don't want it to be my first 10 rodeos. I want every one of my cases to be great. and photograph, photograph, photograph. You couldn't take too many pictures, because when you look back, you'll see where did you fall short, where did you feel like you hit the mark, and where did you excel. And then you can go back and say, did I look at the KT like I was supposed to critically? Did I look at things? Did I also look at the contacts? You can flatten contacts, right? You don't have to accept the shape of number 7 or even number 9. You could pick whatever you want to do, and you could say, I'm going to make these contacts broader to help close in that black triangle or prevent that black triangle. But these are conversations that you can have if you put the photograph up on a big screen for the patient to say, what would you like to do? Here's my recommendations, but it's better to explain the whole case before you get started right there. Not bad. I mean, it's the same day. This is a 1-year follow-up, but just from this straight on view right there. So I think we've done a reasonable job. I'll keep taking pictures of this case at 2 years, 3 years, 5 years, and go from there. But I'll show you a 12-year follow-up on 2 congenitally missing laterals, and you'll see how we're able to manage that case right there. Now we'll move on to the second case. You guys saw this one at the very beginning, right? Patient walks in, and I remember this like it was yesterday, because I have no idea how I got mixed up in this case, and I should have never gotten mixed up in this case, but I did. This patient was so adamant that she wanted me to take the X-ray personally, and I have not taken an X-ray in 20-some years. And she literally drugged me and said, I don't want any nurse, which obviously is not a nurse, assistant, to take the X-ray. And I tried to explain to her, I said, you don't want to take this X-ray. I've never taken an X-ray in 20-some years. She's like, nope, I'm afraid they're going to hit my tooth and it's going to fall out. And I see it, I don't know which one. Is it 7? Is it 8? So I was like, well, it doesn't look like it's going to fall out to me. I said, you just super glue it back in? She's like, no, I've not super glued anything, but I don't want anybody to touch it. So I took the X-ray, and this is what we see. So should I have run for the hills? Absolutely. I think she could have sneezed and it could have come flying out. How this is in her head, I have no idea. How she's been walking around like this for years, I have no idea. But patients present with the craziest thing. I see this on my screen, and I'm like, oh my God, why did I come to work today? I should just run away. But nonetheless, she's there, right? We have to do something, or we don't have to do something. We can decline the case if we want to. But I start taking my photographs, and here I literally should have run, because what do you see here that makes you pause? Would you love to join this case as your first 1, 10, 100? I don't care what number you're on. What are the aesthetic risks here? Well, color match. Is that going to be hard or easy? Is that a high lip line? Oh my God. This I think could wrap to her forehead if she really tried. This is a huge aesthetic risk right here, because look at that lip line. The transition is so high. We can't afford anything. And then what do you see about the shape of her teeth? Are they big and square, or are they not? Well, they're not. They're tapered. And what do you think about the scalp of her papilla? Is it flat? Oh my God, look at that thing. It goes all the way up to probably the incisal third. So there's so many things that are just going to work against me. But sometimes you got to be careful what you wish for, because patients start to talk and they're like, well, that Patel guy does a lot of implants. The Patel guy's pretty good. And I'm not trying to pat myself on the back, but when patients walk in and say that, they're like, oh my God, why did you guys pick me? I'm just your average Main Street dentist who happens to have a titanium screw every once in a while that it works well. But she was like, you're the guy, you're going to do it. And I went over all this with her that day because I was like, man, I really feel more comfortable if I don't do this case. And she's like, no. And I said, here are all the risks. And she's like, no, you're going to be the guy. So what do we do? I think she sneezed and it fell out of her mouth. And here's this crown laying in my hand. And I'm like, oh dear God, I guess I'm committed at this point. So we took the tooth out. How do we get the tooth out? I mean, if I go back to these slides, are you going to get a 301 elevator in there? Are you going to get a periotome in there? So what do you think I used? And I'll let you, munch on that. But our idea is, can we get that tooth root out, which has been root canaled and hollowed on the inside, has a bunch of decay in it, maybe some internal or external resorption going on there. But we got to get that thing out and preserve as much of the buccal architecture, or all the buccal architecture, as possible. So we're able to with that weight 859, right? So then if we can hug that palatal plate, just like Dr. Hahn keeps on talking about, give us that space, a minimum of 2 millimeters. I'd like to see 3 millimeters of space between my implant and that buccal bone. But if we can get the implant in, then we're doing a pretty good job. If I stick an osteogen plug in there, I get this implant in there. I think I might even tuck a little piece of alloderm down inside between the KT and the bone, the periosteum. And I put my little tall healing cap on there, because my goal is that if I can let that sit for a minute, What am I going to do? I'm going to take my CT scan, actually make sure I got the implant in where I wanted to, stay away from the inside of the canal, give me 2 millimeters of bone across the front of that. Feeling pretty good about that. Then I put a temporary cylinder on there because I've got enough. I've got plenty of good stability to this implant. So I was like, well, this papilla scares me to death. Whatever I can do to try to keep that, I'm going to. So I put my temporary cylinder on there and I scan it with my optical scanner, and I carried it over to my fast design. And I'm going to homebrew something here. So I've got a biotemp block, or I can't remember if it's a camouflage block. Whatever I had, I was going to make something. So I did a rough design right here. Okay, so we milled it out of camouflage, which is still a composite ceramic block. And I'm going to make my own homebrew temporary for the patient. Could I have used that number 8 that she had? That was my plan. I went to go drill inside of it, and whole tooth just shattered into a million pieces, and I wasn't smart enough to take an impression of it ahead of time. So I had to do something. So this is what I came up with, and we made a little screw attempt, cleaned it up, and we get it in place. And this is, I think, about a 3-week, I can't remember exactly, post-op. It's okay. I mean, I'm patting myself on the back, like, dear God, thank goodness that I'm doing a pretty reasonable job. Is it perfect? Absolutely not. Is it better than a C? Yeah, I give myself about a B minus here. So I'm thinking, all right, got a chance of keeping things the way that they are. But nature is going to take over nature. Here she is now. Everything is healed. It's been 4 months. We unscrewed the temporary. I think we've done a pretty decent job keeping KT, right? I think we did a pretty good job making that emergence profile. I don't think we did a great job in those papillas. You can't really see it too much from this angle, but it's not perfect. It has receded quite a bit. Look where we end up. Look at that stippling and look at the call of that, right? So we've lost at least 50% of that papilla, even with the temporary in place from the day of extraction. We've got good KT. We just don't have that papilla. But the only way out of this case is that you've explained that to the patient from the get-go. If you hadn't sat down and said, there is no way to guarantee this, then I think you're going to be in trouble, right? So we continue on with our process. We order our crown or our hybrid abutment, and we get it in, and then we unscrew our temporary, evaluate everything, and we get in our aesthetic crown. Did she want to do a crown on 9? I told her at some point, probably yes. Did she want to do something on tooth number 7? 7, not yet. Is it acceptable? It's acceptable. Is it perfect? No. Is it anything else I could do? Maybe. I don't know. I wish I could have grown that papilla taller, but that wasn't in the cards for my skill set. Maybe it wasn't in the cards for her healing ability. I don't know. But I don't try to blame the patient. I try to look at every case and say, did I do the best I could based off the circumstances I had? And the answer is, I think I did as much as I could. The soft tissue around the implant, I think, looks pretty darn good for what we have. Is it perfect? No, but that's where we are. So I give myself probably a B minus on this case right there. Some of it on my ability, some of maybe on the patient's ability to maintain that tissue. But the key is, if she's happy, then I'm okay with it. And this is another case that I'm not going to show the full case, but you're going to get some congenitally missing laterals. This is a great place to start with a CT scan, order a guide, and use the 3 millimeter Hahn implants. So this is how the patient presented. And I happened to just have her come back in hygiene one day, and I said, I don't really remember doing the case. And I pulled up her original photograph. Well, look at that. That thing was done somewhere. And I don't know why it says modified on 14, but created on the 15th. So I'm going to go with that. I took this picture on the 14th, 2014. And here it is, 10 years later. And I think we've done a pretty reasonable job in maintaining where we started from in this case right there. So I think we can have good results if we pay attention to the KT, pay attention to the KT, pay attention to the KT. All right. Speaking of KT, we'll end with this. Then we'll have time for some questions and answers. So when we see, a case like this is kind of right outside the aesthetic zone, right behind the canine. Could it be considered? Maybe single tooth, but the idea is, anytime we see this, invagination of the tissue, is it a tissue defect? Is it a bone defect? Is it one or the other, or is it a combination? Your CT scan will tell you a few things, and the CT scan may not tell you a few things. But this case right here, I think I'm going to show, because it shows you a little bit of soft tissue manipulation, and some ideas might run through your brain on how to keep that soft tissue profile. how to get that mucogingival junction as far away and give you that 3 millimeters of KT that I want around every single one of your implants. But here we're going to make a more of a palatal incision, or lingualized incision, and we're going to flip that tissue up and get it out of the way. So then we can assess, is it a tissue defect or is it a bony defect? Well, look how much bone we have here. So I don't know that it's really a bony defect. I think it's going to be a little bit of, we got to beef up that tissue since we got that invagination going on. So we look at our bone and we can pick our appropriate sized implant, and you guys understand how to place implants, so we don't need to go through the concept of that. But we go through our initial drill, our x-rays to make sure we're splitting the uprights correctly. We get our final shaping drill, and then we get our Han implant, and that goes into place. That's very easy to see, right? So we got an implant nicely placed in between the two uprights. Could be a screw retained crown if that's what we decide to have in the end. And we look at how much buccal bone we have. At a minimum, how much do you guys want? 1 millimeter, 2 millimeters, 0 millimeters? Well, I mean, I think intuitively we've heard this. You got to have 2 millimeters of buccal bone, right? And I'm going to show you some research PubMed articles here in a minute. But when we look at this case, we got the probe up there. We got 1, 2, 3. So we got 3 millimeters of buccal bone. That's fantastic. If I can get 3 millimeters of buccal bone on every single one of my cases, I'd be jumping up and down. Do I expect that? No. If I have anything less than 2, light bulb's going to go off in the brain saying, maybe I should do some buccal grafting. Maybe I should beef up the tissue as well. But since there's a defect here, I'm going to say this is not a defect of the bone, but this is a defect of what kind of tissue I got surrounding my implant right there. So if we look at this sort of PubMed study that we got, it says, what's the correlation in that buccal bone thickness, the BBT, and what happens over the course of time? And the answer is probably exactly what you think, right? The amount of buccal bone across the front of our implants really pays a huge importance to what the long-term outcome is of our implant, especially in the anterior or the aesthetic zone right there. So if we look at the study, I think it's pretty nicely done. About 75 implants, and grouped them into groups, right? They said, well, group 1, Patel did most of these. There's only 0.5 millimeters of bone. Group 2, better doctor did it. He had a little bit about 1.5 to a 0.5 millimeter bone. And then group 3 was all you guys down there in Florida. You got greater than 1.5 millimeters of bone. So you guys got the best chance of long-term success. So group 1, group 2, group 3, all taken at the time of implant placement, right? So what do you think is going to happen? Well, I mean, the answer is you probably know what's going to happen. So if they looked at the soft tissue around these implants, group 1, group 2, and group 3, at 1 year, 2 years, and 3 years, what do you suppose happened? Now, I looked at this, I was like, well, that's kind of weird, but kind of what I expected. Group 1, they lost about 1 millimeter of gum tissue around that implant. So if I'm placing implants and these are mine in group 1, I got about 25 of them, and my patients lost around 1 millimeter of tissue, I'm going to have to move from North Carolina and come join you guys down in Florida because they're going to be looking for me and say, Patel, I see all this, craziness in my implant. I don't really love it. Group 2, well, they lost, around 0.5 millimeter. It's not as bad, but makes sense, right? Because some of them had 0.5 and some of them had all the way up to 1.5. It'd been great if they said this group was only, greater than 1 millimeter to see what that would have done. Would that have been less than 0.6? But this is the way the study was done. And group 3 shocked me. Shocking. I mean, if you've got greater than 1.5 millimeters of bone, that actually grew some tissue. Is that even possible? Well, I mean, I'm not going to argue with the study, but that is what happened right there. So even if we're not able to get more tissue, even if a papilla didn't creep, the light bulb is, give me as much bone across the front of that implant as possible in the aesthetic zone. So if you can't get 2 millimeters of bone across the front of that implant, then my suggestion is we do some grafting around that implant of bone, okay? Or build up the site, or use densa burrs, or expand the ridge, whatever's within your wheelhouse, because we got to get that bone there. And then we got to get the Patel rule of threes of the tissue across the front of that. And then I think you're going to have good long-term success. So conclusion for some of these things in the aesthetic zone, got to have 1 millimeter, 1.5 millimeters. I'm going to say stick with 2 millimeters of bone as your base cutoff. If you've got the width, pick the right implant size, and make sure the bone is there across the front. What are some other factors to consider? Well, you guys know that in the Han implant system, that is a machined collar, right? Why is it machined? Well, bone is happy against it and tissue is happy against it. It is not polished, but it is machined. So both of those things will be happy around there. So implant design has some bearing and effect to the long-term stability of your restoration. How close is it to the natural tooth? You know, laterals, right? Notorious thin spaces. What's the average size of a lateral? About 6, maybe 7 millimeters. Are we going to try to jam a 3.5 millimeter implant there? No. We're going to use a specialty 3 millimeter implant because we got 3 millimeter implant, gives you 1.5 millimeters, and 1.5 millimeters to get you 6 millimeters. That's the bare minimum width that you want between the implant and the natural teeth. Implants are not teeth. Implants are not teeth. Implants are not teeth. Right? You've heard that over and over and over. Why? We got to have the bone because we got to nourish that complex, and that complex takes way more bone than a natural tooth. The natural tooth can sit outside of the bony complex and be fine. An implant sitting outside the bony complex doesn't work out well without that 1.5 millimeters or 2 millimeters because it's not properly nourished. If it's not properly nourished, we start to see that periosteum pull, then we start to see that soft tissue pull, then we start to see periimplantitis, and then you're wondering, why does this happen to me? So we start to think and look back at our cases and say, was there that bone to start with? Was there 3 millimeters of KTs to start with? Then we got to do it. Implant diameter. I mean, am I jamming 5 millimeter implants for centrals anymore? No, I'd rather have that. I mean, I'm completely happy with a 4.3 for a central. I'm completely happy with the 4.3 for a canine. So don't get into the trap that it's a big rooted tooth and it needs a 5 millimeter implant. Well, my 5 millimeter implants are pretty much molars. I'm not putting those in the anterior. You got to have good, robust 2 millimeters of bone across the fronts of those right there. The depth of the implant placement, and we're going to cover this in the next 5 minutes, so we have room for some questions, but I'm going to talk to you about soft tissue. What do you do if you don't have 3 millimeters? Occlusally, where you're going to start to think about placing that implant platform right there. So this is our famous best friend, Lithuanian periodontist dentist, and you guys have heard of Linkevicius, right? This is not my case. This is his article, so I'm not saying these are my photographs. They're his photographs from his article. You can look up this article, but the idea is if the patient does not have 3 millimeters of native KT occlusally from your implant, what are we going to start thinking about doing? On the right-hand side, what do we see? We got about 1 millimeter or maybe 1.5 millimeters of tissue. Do we want to place that implant supracrustally? Heck no. Do we want to place that implant equicrustally? Heck no. Do we want to submerge that implant? Absolutely, because we want the biologic width to get traded off. In that case, you see on the right-hand side, if that was literally 1.5 millimeters of soft tissue occlusally, we're going to push that implant typically 1.5 millimeters because the biology will happen and we will trade that bone off for soft tissue. And that soft tissue will be KT on top of our implant. So I encourage you guys to pull this article up and read it because it is a fantastic mind opener to get you guys to understand where platforms to be. So the idea is if we look at, this is my case, right? That if I look at the tissue and only have 2 millimeters of tissue, what am I going to start doing? Well, you can see exactly from this probe, what did I do? I buried that implant 1 millimeter below the crust of the bone because I want this patient to have as much protection at the top of that implant as possible. So we're going to submerge that by 1 millimeter. Put it down, make that soft tissue happen right there. This is that case that we showed. We had that buccal tissue defect. So when should we deal with this defect? Should we do it now? Should we do it when we take the flat cap off? Should we do it when we go to restore it, put the tall cap on it? Or should we do it after we got the crown in place? Well, I mean, obviously there's some right answers here, some wrong ones. We've already made the flap, so I think we deal with it now. You could do it at second stage. Doing it at restoration slows down the process, and doing it post-restoration is because something did go wrong. I certainly don't want to do it then. So I'm kind of measuring how much space I have here. When I say space, what kind of defect, what kind of tissue am I going to need to get right here? Patient's done, put the implant in place. So I'm going to go over here and say, I'm going to go grab a piece of palatal tissue. Why not? I mean, I got nothing better to do. It's free. So I'm going to go ahead and harvest a little piece of connective tissue. And, we don't have time to go through all of this, but, the idea is to stay away from the free gingival margin by at least a couple of millimeters. And then everyone's scared about the super scary thing, which looks like a tree trunk or a root branch down here on this lower right-hand side. What's that? That's the palatine artery, right? So we know how it travels. And if we stay within this zone, we got plenty of width. We're not going to run into the darn thing. So you can go grab your piece of connective tissue. Now, some people have enough surgical skill set they can grab that, internal piece of connective tissue. I'm not that talented. So I'm just going to take the whole fillet. And, can you get it from here or can you get it from the tuberosity? Well, if they don't have third molars, yeah, grab it from the tuberosity. Tuberosity is actually better for that kind of connective tissue that was real robust, has less fatty tissue. But, in this particular case, we got it from there. But if you got it from the tuberosity, it doesn't bleed. It's real easy to go. It's actually better for KT, rich in connective tissue fibers, and you don't have to worry about the fatty tissue. There's really none back there. No glandular tissue, and really it doesn't complain when you grab a piece of their tuberosity. So there's very, very little downside to doing that right there because of all the things I'm listing right there. And it's actually going to shrink less than grabbing a piece of the pie. Now, the other thing that you can do is you can get some acellular dermis. What is that? That's like saying that you got some alloderm. Alloderm is the brand name. Acellular dermis is the trade name. Or not trade name, but the non-biohorizon name. You can get it from anywhere. It's about $90 for a piece of alloderm, and that requires no surgical skills except for opening up the package, hydrating it, and shoving it in between the layers of tissue right there. So for those of you who don't understand the V incision and the tuberosity, here it is drawn out for you. Okay, right? You go behind the second molar, big old piece of tuberosity, big old piece of tissue. You basically just make a V cut, take that out, and then you can suture it. The patient's never going to complain, and you've done your first connective tissue graft. This is a fantastic idea to build your surgical skill set. If you want to learn how to do this, patient's numb, we grabbed it, you can see all that fatty tissue, right? So we're going to have to scrape that off. Doctors make things so much more difficult than it needs to be. That's all. How do you scrape it off? How do you know you didn't take any more of it away? You literally just put it on a piece of gauze and scrape away until you see white. And now you have removed it. You flip it over to the other side. For those of you who've scaled a fish, how do you know you've taken the scales off fish? You run your knife across it, and when it doesn't flake off anymore, you've gotten rid of it. The epithelium will come off of it just like I showed right there. Now you've got your piece of connective tissue. That is the fillet that you're looking for. And you're going to just simply slide that underneath your flap. This happens to be on the buckle right there where we're tucking it in, and we're going to use some non-resorbed suture to hold down the apical portion of it. So this is our connective tissue graft, right? Was it that difficult? No. If you got it from the tuberosity, it would have been even easier. If you didn't feel the love, you could order a piece of alloderm and shove it underneath there. And then you just suture it down, close it together. For those of you that say, I don't know how to get it between the tissue and through there, well, you got these little corn pliers right here. I got the little hole in there that makes it a little bit easier to suture it. And then we got our, non-resorb suture. We got our PTFE closing it in place. And then we got to deal with this defect that I've created in the patient's mouth. Can we make a clear step? Can we make it further? Could we do some periopack? Could we do some collagen tape? Could we go draw some blood and make some PFR? Do we do collagen tape and pericryl? Pericryl is super glue for the mouth, or do we just say, we really don't care, you've paid us, and we're going to move on, and sorry, Miss Smith, here's some Vicodin, and deal with it. Probably not that. I'm just kidding when I say all that right there. So we're going to pick something that we see here. Well, good thing is I've got a study here for you to show what is the best choice out of all those things that I told you right there. And they broke everybody into groups. Now, intuitively thinking, which one's going to be the best, so they broke them up into some groups, right? Control group, they just threw some sutures in there. I don't sound like it's going to be all that good. The other group, they just put some pericryl in. Well, maybe. The other group put periopack. Well, I've heard of periopack before. I've heard some periodontists using that silly putty around teeth and the grafts. Okay, maybe that would work. Or maybe they just threw some collagen tape. That's some collagen tape with sutures right there. Or they did collagen tape and pericryl. Collagen tape and super glue for the mouth. And then we look at all those choices, and surprisingly enough, putting the piece of collagen tape with no sutures and just some pericryl produced the least amount of pain and maintained it that way for the length of the study. And I was like, that's fantastic. So the control was doing nothing. Like you see it everybody start off with lots of pain, right? They start off the most, and it took them the longest 2 weeks to get down there, and they still didn't get to where the people with the collagen tape and the pericryl or the super glue for the mouth. And you can see even those that had just look at the left-hand side. I mean, it's amazing the difference that the patients had in pain right there. So if we need to do something, collagen tape and super glue for the mouth does wonders for right there. And here we are about 3 weeks post-op, took the sutures out 2 weeks, and that's looking pretty good, I mean, I'm feeling pretty good about it. I'm not saying I'm a periodontist. I'm not saying I've got the skill set of a periodontist, but I feel like we solved that mucogingival defect. I feel like my implant is going to have good, robust bone around it. I feel like my implant's going to have 3 millimeters of KT because we buried that sucker a millimeter below it. So we're going to trade that off to get 2, turns into 3. I know that palatally we got robust tissue. It's just palatal. And then this away, we got bunches and gobs of KT. So this is what I want you guys to dream of. Sleep at night thinking about keratinized tissue around your implants right there. Well, I'll stop here, and that gives us only a few minutes, but hopefully some good questions. Get an implant with a machine collar. Pick one that's implant shifted or platform shifted. Consider the use of a gold anodized abutment or a hybrid abutment. Consider a screw-mentable crown. If you have not understood what a screw-mentable crown is, then you can watch Dr. Manley's video on that. And then obviously you're going to use a lab that understands implant restorations. Okay, so I'll stop there. I'll turn it back over to whoever's in charge of the questions. I don't know exactly if that's going to be Nicole or what, but I'm happy to spend as much time as we need to make that happen.